Okay. The macroeconomic trends and the impact of Ohio service realignment, and we're going to talk about conversions and downsizings on ICFs, ICF IID reimbursement, and what's going on in the MBR actually today. That's how fast it's moving. ACA, impact on wages and benefits, home health services, and probably a couple other things. Just to kind of paint an overview, because sometimes we get lost in the weeds in where we are in the system and instead of the system itself. I kind of just listed what our service delivery system looks like today, and each one of the components in very, very, very broad parameters of each. You know, we have the entitlement program, we have the ICF. The ICF is the comprehensive program. It frankly includes everything except for medical services for all practical purposes. So from there we have the individual options waiver, which is the next most comprehensive service, and everything is a la carte. It's free choice of provider. The two major, well actually the four major services under that waiver, as we know, are homemaker personal care, transportation, adult day array services, and non-medical transportation to and from that service. That makes up 99% of all of the services under that waiver, even though there are many other services that are frankly lost and forgotten. We have room and board in licensed settings, non-ICF. We're probably down to maybe 2,600 beds in the state of Ohio now, where people are on waivers and receive services in a licensed setting. Room and board contracts have become a major, major issue in the past several years, as many of you know, as well as cost to live has become a major issue in non-licensed homes, because the expectation is that, you know, folks will live on their own money. And we know that as a practical matter, in many, many, many places, many, many different circumstances, that's not true. And all the pressures that is putting on the provider community, both in a financial way, but also in a regulatory way. Some of you have had claim fund audits in recent years, and how those are being approached and how the department views the usage of and the control of the individual's funds has been more than enlightening as we continue to look at the system changing. Hi Ross, I'm glad you could make it. Thank you. On top of that, we have add-ons for behavior and medical. And I'm going to talk a little bit about, yes, they're there, but what has happened to them in the scheme of things. I'm also going to talk about what's happened to routine homemaker personal care and on-site on call and how that's affecting everybody financially. Level 1 waiver. By the way, we have approximately 17,000 people on the IO waiver today. The approximate cost, and by the way, when I spit these numbers out, there's a reason why I'm saying approximate, is because we have no real good data collection system in the state of Ohio to codify these numbers. And the exercise that it takes to go through getting good numbers is unbelievable. So some of the numbers I'm going to talk about are a little bit historical, but at the same time I'll try and update them with, you know, what our guesses are they are today. Level 1 waiver now has over 14,000, probably broaching 15,000 people on the level 1 waiver. This waiver is our next, in my estimation, our next disaster. This was the refinance waiver. This was really targeted towards taking folks that were getting county board services and refinancing it and throwing on a sprinkle of what we would consider to be, you know, residential type services, homemaker personal care and transportation. But it was really to refinance day services at the county board level. The issue is these 14,000 people now have aging parents, they have parents with medical issues, they have you name it, and it's going on. And I can't remember the last week that one of you guys didn't call me and say something to the effect of, the county board would like to move a person on a level 1 waiver into one of our settings to share services, and we're now going to pretend they don't need anything because they can only get 4 hours a week, because that's all the money there is under that waiver, and all the complications that this is now causing. This problem is going to get worse. It is not going to get better. And we don't have a good system in place currently to address it. The self-waiver is very, 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 very new. I don't know how many people are on it yet. Probably less than 100. But I can tell you also get these phone calls from a lot of you folks because they want to share services with people that are on the IO waiver, and then we run into the same types of problems. The additional problem, though, is for people on the self-waiver, there are no ratio rates. Okay, so when people start to find out, well, wait a minute, yeah, I can share services with somebody, but my share of the staff cost is the full rate, then all of a sudden they don't want to share services anymore. So it's got all of its issues also. I'm just going to point this out, that the definition or the main service is not homemaker personal care, it's community inclusion. The definition of community inclusion is 1 sentence long, and it is not a long sentence. So I'm frankly still trying to figure out what it is. You also can get clinical therapeutic intervention and functional behavior assessment. All of those have adult day array services, supported employment, non-medical transportation attached to them. And then we have the TDD waiver, which is the transitions waiver from the Ohio Home Care waiver for people with disabilities. The reason why it's called transitions is they're not supposed to be on it. And we have the same myriad of issues with those folks that we have with people on the level 1 waiver. The responsibilities of managing that waiver have now been transferred to the county boards. And frankly, as one person at the department told me not too long ago, we are learning what all the options are that are available to the other waivers through our experience with the TD waiver, so my ears perked up a lot when they said that. And another subject matter that I'm going to touch on is home health services, because that's predominantly where these folks are getting services from. And so now we're starting to see the overlay of that thought process now onto people on the level 1 waiver and people on the IO waiver. Am I talking to the right people? I see some heads going like this. Okay. I went through this earlier, so these are the subject matters that we're going to discuss. I'm not going to spend a lot of time on it again. Just some overarching numbers. Some of you have seen this before, some of you have not, but to refresh your memory, state developmental centers, at the time we gathered this data, there were 1,275 people. Now we're under 1,000 people in developmental centers. The average cost, $500 a day, $183,000 a year. In the private ICF system, about 5,700 folks, 5,800. Now it's down a little bit because of some downsizing and conversions, but the average cost at $277 a day. Pretty large difference. The IO waiver, and I'm going to talk a lot more about these numbers when we flush them out and start comparing apples to apples. But on the surface, it looks like it's less. It's $60,000, right? A little over 17,000 people. Level 1 waiver, at the time of this data collection, it was about 10,000 people. Now we're over 14,000 people, and the average cost is about $11,000 a year. Pardon? Yeah. Yep. So when you do the math, one of the opportunities we have in the system is as DCs continue to downsize, And folks either go on waivers or now what is also happening is the creation of some new ICFs that are strategically placed near developmental centers for more folks to go out into. As we continue to take people out of DCs, we start to free up money in the system. If we were to eliminate that system and transfer everybody, arguably I did what I call my napkin math. Mark Davis and I love to call it that because we could do it on a napkin. We don't need much of anything else. I just compared it to the highest rates you could possibly have in the, under Title 19 in a private ICF system, which would be around $355, or excuse me, $372 a day, and compared that to the current expenditure into DCs, and lo and behold, you have a state match difference of about $22 million that would be freed up. It's not an insurmountable amount of money. I'm going to go on to talking about what's going on in the ICFs right now. It's been pretty complicated to follow, but basically we have a formulary in state law, and then we have temporary budget language that has basically overlaid that formulary that's in permanent state law for a good number of years now. And we've gone through the process of having a state cap put in place. So frankly, what that means is in a reimbursement system, we calculate rates based on a formula. So it's, you know, it's very prescriptive math. But then we say, oops, we only have X amount of money. So what we do is we roll back everybody's rates consistently by the same percentage amount to get back to the maximum amount of money we're going to spend in the system. And we had rate freezes during that time period. We had rollbacks during that time period to get to the same result. And then starting about 4 years ago, we started really diving into the numbers and said, wait a minute, the rollback is not tenable in the stability of the system, because what it does is it takes the most efficient providers, and I get, by the way, I get slammed for using certain words, but if anybody has a better word, please raise their hand. But I will say those providers that maintain good quality care at a reasonable price. Is that better than efficient? They were getting penalized the most. And the providers that had higher cost according to acuity, that's another way to say it, were getting less penalized. And what was happening mathematically, because of how the system formulary works, is the high cost was dragging more money up the chain to the providers that spent more. And for the ones that were really towing the line and trying to keep costs at a reasonable level, their rates got rolled back at the same percentage. And it was becoming extremely untenable for those providers, because every year what you got to look forward to was, if you did a better job this year, you would get less the next year. And that downward spiral can only occur for a certain time frame until you start to have tremendous instability within your system, and now you are talking about quality of care. So we instituted 4 years ago a modified formula, trying to get at those issues and trying to mitigate and get people to start to change their behavior financially so that we could get people all on the same playing field. Well, in a nutshell, where we are at today is that first blush was go 50% rollback, 50% modified formula to soften the blow. And now, through this budget bill process. This next year, rates will be set with the target goal of 0% rollback and ceilings established within the state cap so that there's no longer a rollback, but now you're subject to lower ceilings. At the same time, we had a project going on around the assessment instrument that sets the direct care ceiling called the IF. And we had a rebasing of that, which and also included going from 4 different rack groups to 6 rack groups. So the math changed. So a couple months ago, still under the current temporary law, we had hard-coded ceilings for direct for large facilities and small facilities that were the same as the year before, and we started to take a look at the impact of that. And I was sitting in my chair when I think I called Anita the first time, and I said, I must have done something wrong. My math must be, maybe I ought to go home and do the math tomorrow. But for the first time, because of 2 shifts, number one, because of the fact that we went to 6 rack groups, and because the department went out and reclarified how we were supposed to be answering questions on the IF, and we still don't know to the extent which one is, the bigger culprit than the other. We now had a shift where the average cost per case mix unit, which means the cost of direct divided by the case mix score, flip-flopped from the large facilities having a higher one to the small facilities having a higher one. So I'm going to walk through the math with you. Currently, we have 271 small facilities, those are 8 or less. We have 142 large facilities, which are 9 or greater. So when we talk large and small, that's all it means. That's 65%, 34%. But we have 66% of the people living in a large facility and 33% living in small facilities. You would think that that's a coincidence, but it's really not a coincidence when you do the math. It's a flip-flop of percentages. The average bed size in the smalls is 6.9, because frankly the most common small is an 8 still today. And the average bed size in the large is 26.1. But that ranges all the way from 100 plus down to 9 beds. The average cost per case mix unit, the average cost per case mix unit now for the smalls is $112.23 and the large is $110.48. It used to be the other way around. So when we started looking at the hard-coated ceilings, I went, oh my gosh, the average cost per case, the average case mix score in the smalls went down to 1.65. The larges went to 1.84. They were both very, very close to 1.87 before the education on how we're going to answer the questions and before we expanded to the 6 rack groups. The 2 were very, very, very similar. They both went down, but the smalls went down disproportionately more. So what does that do to ceilings? What we ended up with was, if we didn't adjust the ceiling, and believe me, this was a scramble about a month ago to get everybody on board, but if we didn't do that, we would have had 51% of the small facilities covered under the direct ceiling, and at the same time, we would have had 72% of the large facilities covered under the direct ceiling. So we got everybody back together, went through all the math, and what we're now projecting, and what's in the MBR language that is where today, Anita? It's on the Senate floor today? Okay. That language now not only says that there will be an adjustment in the ceilings, but we're actually going to calculate it based on 2013 actual cost. So I know what I'm going to be doing about the last 2 months of June, and Pete from Ohio Healthcare and Pat McCormick and a couple of other people, is we're going to be doing the math because the department doesn't have a system to do the math that quickly. So we're going to come back together. We'll all agree on what we believe the numbers are, and we'll all come at them with the same database but independently, and we'll all be extremely close together because we all three know how to do it. So this is highly controversial. What we have going on, and everything we've talked about earlier, is we have large facilities that are being highly encouraged to downsize. Those large facilities are saying, we will become less efficient. We need the money. We have the small facilities saying, wait a minute, we're going to get slaughtered at the same time. I'm saying, what good would it do to downsize to small if only 51% of their costs is going to get covered under the largest ceiling? That's called leading somebody to the slaughter. So no matter what we do, as long as we have this state cap in place where we are frankly ratcheting down rates to the tune of $25 million a year in this system, and I'll paint that a little bit better in a minute, we're going to have some type of pain that needs to be shared until we change that dynamic. But what we can't have is a system that says, we're encouraging you to downsize, we want you to downsize, we're going to do all these things for you to downsize, but when you get there, you're not going to like where you are. Also, it's important to note that also in that MBR, we are creating a third peer group. So currently, there's two peer groups, large and small, and how ceilings are applied and how they're calculated, and so therefore how the reimbursement works is divvied up between larges and smalls in the area of indirect, capital, and direct. The only one that's not affected by that is protected, which is the smallest ceiling. Actually, there is no ceiling in protected, that's why we call it protected. But the other three major categories are done within those two peer groups. The third peer group will now be the DC downsize 120 beds that are projected to go online next year. The reason why we're creating a third peer group is for two reasons. One, to have a different funding mechanism for them, and number two, for it not to have a financial effect in a negative way to the rest of the system. So blending them in with the rest of the system, and they would all be smalls, would make this math look even worse. So that's, I mean, frankly, not even close to being a good idea from a stability standpoint in the system. So these are just projection numbers right now. We were actually not thinking that the department would go along with us to use the actual 2013 data, that we thought that they would probably take a hard stance on us guessing what it was going to be and putting it in place now. But the problem with that is the way the language is written, there would either be a roll up or a roll back by the amount that we would be off. And there's a fear that it would be a roll up, which politically would not be a good place to be in. You calculate a Medicaid rate, and then you add something more to it. I don't want to explain that to a legislator, and I don't think anybody else in this room wants to either. Okay, so we didn't want to be in that position. At the same time, we didn't want to be in a position where we could be off and be conservative enough that we would end up with a significant rollback, because that would mitigate everything we've tried to do. So in the best of all worlds, we came out with more than what we probably thought we were going to, providing the whole package goes through. Now, by the way, this MBR, it is a package. So what the department has done is said, we're going to put it all into one, all of these changes, and then we would really like the associations to help us with this. And if you all agree, then we're all happy. I talked about the MBR and the third peer group as a separate direct ceiling. The RAC scores, We're also expecting a increase in what are now called exception reviews. And some of you have already had these. That's where the department comes out and they look at your IF scores and they either agree with you or don't agree with you based on documentation. And the ones that I've been aware of that have happened in the last month, they didn't spend very much time. And they didn't look at every question in the IAF. They looked at target questions, and yes, you guessed it, they were around behavior. And maybe medical, depending upon the facility that was being looked at, but the vast majority is around behavior. There is no appeal process other than you get to disagree once. You send it in with all your supporting documentation. If they disagree with you, there is no further appeal. That decision is final. So I encourage everybody that if you are unsure of what you need documentation-wise around behavior, behavior is the hardest one. The reason why it's the hardest one is if you're doing a good job, you're mitigating behavior, right? Well, if you're mitigating behavior, are you mitigating behavior because somebody is cured? Or are you mitigating behavior because of proactive measures? I would submit that for the large part of it, the second one is the answer. How do you document something that didn't happen? That's what you're now charged with. You have to document your proactive measures to mitigate the behavior to claim that score. Well, I mean, we're all going to learn what's going to suffice and what's not going to suffice. What I'm encouraging providers to do right now when they have a review is if you didn't think that the documentation was sufficient, or if you didn't think that the evidence was sufficient, then please tell me what that would look like. So don't let it drop. These will affect only the quarter that they come out to review, which is real important. So it's going to affect 1/4 of your score. But what the department will do is if you have 7 out of 8 people in an 8-person site that all have, question 17 with a 3, and they come out and they give all 7 of those zeros, and you submit your next IAF and you have all 7 of those people with 3s again, expect a phone call. They will be back. So it's not going to be over. So, from the standpoint of will that 1/4 affect your reimbursement, and there's a lot of rhetoric about, it's going to drop your rate right now. Frankly, not necessarily. In fact, in most cases, it may not. It depends upon where you are in relationship to ceilings. But it is going to set up a trend, and the department is going to use trends and who they target to do exception reviews. So right now they're calling it random. I'm not sure if I agree with that or not, based upon what I've looked at. But in the future they have made it clear that they will base it on trends. And they will base it on, if you go back immediately to that score, they're going to want to see why, and they're going to want to see the documentation. Okay? So I encourage you, the most important part of this exercise is if you didn't like what you came and saw, what would you would like to see look like? Please tell me what it is. Don't make me keep guessing and be wrong.
Just a comment on the threshold that the department has given themselves for coming in and doing the review is very low.
2%. Yeah. 2% is nothing.
Do people answer that question of what it would need to look like?
We haven't asked yet. I mean, believe me, these are fresh. They just started 3 or 4 weeks ago. Okay, so people are just now getting through their appeals. So they're sending stuff in, they're saying, wait a minute, no. And then they're getting back, nope, that's not good enough. So we're now in a position to say, well, what would that look like? One of the largest misconceptions is that the waiver costs less than an ICF. In accordance with federal regulations, the waiver must cost less than an ICF. That's one of the things that the state has to prove year after year after year, is to have a Medicaid waiver, it must cost less than its alternative. Well, the services you get in a waiver are not the same as what you get in an ICF. So complying with the tables that CMS requires us to fill out and prove that we're less, we'll never have an issue with that. From a budgetary practical matter in the state, that's a different picture. First of all, room and board cannot be included in an HCBS waiver, period. Room and board is a pretty large component cost of an ICF. On top of that, there are many services that occur in an ICF that are not available to the waiver, but they are available through the Medicaid card and through core services. So those are not looked at when they're doing the actual comparison. But from a state budget standpoint, it makes a pretty big difference. The average cost of homemaker personal care for a person, I'm just doing IO waiver, about $48,000 a year. Transportation, anybody shocked by that number? $614 a year per person. Where are you guys losing all your money at? Can somebody say transportation? Okay. Average cost of day services, now broaching close to $11,000. By the way, there is a disparity between private day services and county board day services. I didn't give you all these numbers today because I'd be up here for 3 hours. I don't probably have to tell you which direction it's disparate. Average cost of other waiver service, or excuse me, non-medical transportation is half of the day service amount. 50% as much, but driving people around. All other waiver services, $386 a year. That's what I mean by we have all these other services on the waiver, but for all practical purposes, they're not utilized. And then I threw in here, if I could push the right button, the average cost of the SSA function. And that, by the way, the only way I could do the math was including people on the level 1 waiver. The average is over $6,000 per person per year. So really, when you take a look at the average cost of a person on the IO waiver, not including Medicaid card services, not including room and board, is about $71,000 a year. So now I go over to the ICF system. And I take the average cost of a person in the ICF, and now this is cost, not payment, this is cost, $290, because the state cap is less than $290. So I'm doing the most conservative math I know how to do. The average cost of room and board. Take out the $18,000. The average cost of nursing. I take out $10,000 per person per year. The average cost of all the other non-covered waiver services, PT, OT, speech, pharmacology, all the other ones that are in the ICF payment system but not on the waiver side, $68,000 a year. From a state budgetary standpoint, it is arguable that the cost of the ICF is less. Now what we're going to do is we're going to take 500-600 more people out of the ICF system. We're going to put them on a waiver. Will those people be more or less expensive than the average on the waiver today? That's a good question mark. We are going to downsize larger ICFs by 500 or 600 people. Will the total cost at the end of the day be more or less than it currently is in the system because we have a state cap? I think I know the answer. By the way, this is just a little anecdotal stuff. The average cost of room and board in a developmental center is about $74 a day. In private ICFs, before overhead, the other number was with overhead, 44. All these are without overhead. And the average in licensed non-ICF, that's my guess, 25. It might be high. Some of you go, oh, mine's higher. I guarantee you that there's many people in this room that say theirs is lower than people in this room that will say mine is higher. It's all over the board. But for every person we take out of an ICF and put them on a waiver, we now have a room and board or a cost to live issue that is not funded under the Medicaid program. When we did the numbers for the elimination of the ICF program years ago, I calculated that that was a $100 million problem to the state of Ohio. And so when I say a $100 million problem to the state of Ohio, what I really mean is that's a $100 million problem to county boards, because room and board contracts are through county boards.
Gary?
Yeah.
Before you leave that, if you go back to the previous slide, if we look at the cost of, we look at the cost of the waiver, and the service that's not in the waiver that is prohibitive in individuals choosing to go on the waiver and have their needs covered, it's nursing.
Mm-hmm.
We're just beginning to look at the transition waiver, and the problem with it is nursing and the low rate and nursing. So I'm just saying, if we throw that cost into the top of your panel, your presentation there, nursing is probably one of the more expensive services under the waiver if it's ever included.
That's
so
correct.
That discussion is going to be very difficult, even though we need it.
And you'll notice I did not include it up here. So I started out by saying I did numbers the most conservative way I possibly could, because I don't want someone coming and poking holes in them when I make the argument. So you're absolutely correct. I now have a Medicaid card in my pocket. My Medicaid card affords me core nursing services through a home health care agency, and that is not included in these numbers. So although it's not a waiver service, it is a Medicaid cost to the state of Ohio. Okay, so that just makes that number bigger up above, not smaller.
But it's a service you can't get.
Mm-hmm.
The card service getting nursing in Ohio is atrocious.
Mm-hmm. Okay, the next issue that we know we have, and I'm going to try and say this as unbiasedly as possible. When we look at the money that is being spent in our system today, what we know is we have private entities delivering Medicaid services, and we have public entities providing Medicaid services. And the public entities are the county boards of DD. What we know is that the current cost, and this, when I say current, this is 2 years ago, the SSA function, which they built, Targeted Case Management, which is a federal reimbursement program, is about $140 million a year statewide. We know that the reimbursement rate is about $62 an hour. We also know, based on the county board cost reports, that is subsidized by about $45 million of pure levy money on top of the Medicaid rate, and that's after certified public expenditure for match. So again, the most conservative number that I can come up with is they don't get paid the $62. County boards do certified public expenditure for federal funds. So they say, I have spent the match money by paying the employee. Therefore, I certify that I have paid the match, and I prove it by filing a cost report. And so they get paid the federal portion of the $62. This is the amount of money over that, not including certified public expenditure. We also know that on non-medical transportation, that number is about $16 million a year. It's being subsidized through levy funds. We have estimated, and this is a very, very hard number to estimate, but I took the most conservative method I could, because frankly, we have no good data consolidation for services in the state to get information. So I have to take pieces and parts of data to come up with it. Another $116 million a year over and above the Medicaid rate, for a total of $178 million. Then we have county boards that deliver non-Medicaid services, and if I applied the exact same logic, so yes, we know it's non-Medicaid. By the way, some of this is ICF subcontracted day services. So when I say non-Medicaid, it's non-Medicaid to the county board because the ICF is the Medicaid provider, the county board is not. So technically, it is not Medicaid to them. Applying the exact same mathematical logic, I come up with another $246 million for a total of about $400 million that is coming straight out of levy funds to subsidize those Medicaid services. Does anybody here get a subsidy? Raise your hand. Okay. The other thing we know is our homemaker personal care rates, both on-site on-call and homemaker personal care, have now had, well, on-site on-call has had one adjustment since 2005. That was this last year. Excuse me. And routine homemaker personal care is about to have a 5-cent per unit, 20-cent per hour adjustment, the first one since 2005. We know that in 2005, EP&P Consulting, which is the one that did this rate model, came up with an average of $18.73. I updated that model using the exact same numbers that John McCarthy used in 2005 through BLS data and inflationary components and everything else that he used. I came up with $20.10. Homemaker personal care is not the biggest problem. It's about 7%. By the way, that's about $82 million a year in the system. So 7%, although it doesn't look like a big percentage, it's quite a bit of money. I did the same thing on-site on-call. On-site on-call was predicated on minimum wage in 2005. Minimum wage in 2005 was $5.15 an hour. Today, it is $7.95 an hour. So I did the math the exact same way. They came up with 1033 back then. Now come up with 1475. 43% underfunded. A humongous problem. What's the number one change in service today? From what to what? Routine homemaker personal care to on-site on-call. Oh, we were supposed to move this one. I'll go back to that one. Okay. So what does all this mean? I mean, you've heard lots of things about system change that are happening not only from the state level, but also predicated on the federal level today. All of the initiatives of the department to downsize, convert, haven't even started to talk about day programs yet. Probably one of the number one calls I get from you guys today is, Gary, should I even consider expanding my day program? Or should I even consider getting into that business given what the Department of Justice might do to my business tomorrow? I go, that's a really good question. I reached down in my drawer and I can't find that answer right now because we don't know what that's going to look like. When the Department of Justice comes to Ohio and they see something tremendously different than they've seen in other states like Oregon. And that's what I mean by you've got these federal lawsuits and you have CMS regulations that apply to the entire country, but yet the entire country is not homogeneous Each state has their own Medicaid program. Each state has done things differently. And when they come and they look at what each state has done, they're going to have different perceptions and they're going to have different issues than they had from the state that they were in before. So Oregon, which is predominantly sheltered employment, for example, Ohio's not predominantly sheltered employment, but how will they view what you guys have created as day services? This is a segregation lawsuit. It's not just about employment. It's not just about any of these things singularly. How are they going to view you? I don't know the answer yet. What I do know is that given everything that we're talking about, the other major call I get from people is direct service, professional recruitment, and retention. Gary, I'm considering not providing services to people that I am currently today because I can't get staff. These are not exaggerations. Is anybody experiencing that? Is that it? Really? Nobody else is having a problem? The other call I get is, I can't afford any of this anymore. Supervision is becoming a humongous problem in our scattered site system. We used to have home managers. Now we have coordinators. For me, that's code for, we used to have people on site. Now we have people that drop in every once in a while. They're coordinators. We have less of them, which means we have more direct service staff on their little islands by themselves and everything that goes along with that. Here's a big one. I actually did get an application, and they were not on the abuse registry. Check mark. They did not have a criminal background check that prohibited them from working with people with disabilities. That's check mark number 2. They actually showed up for training. That's check number 3. But they have 6 points on their driver's license, and our insurance company won't let them transport people around. Or we gave them the medication administration test, and they flunked it 3 times in a row. Or we actually have to have them do delegated nursing, and the nurse came to us and said, ain't no way I'm delegating anything to them. Or they actually have heard that we have this thing called MUIs in our field. And this is now starting to come about. We have, because we put them with our staff and we say, gee, why don't you go take a look at this and see if this is what you really want to do before we pay you for all this training and you don't show up for work. Because we want to see if they have an aptitude for it and they don't run away after the first day, which, by the way, some of you have told me you're not allowed to do that anymore because that's direct contact and the department has a problem with that. Not that any of these are issues. But this guy is becoming a tremendous problem. So let me get this straight. You're going to pay me $9.50 an hour. I get to work under all these conditions, and I got to learn all this stuff, and I got to be really good at it, because if not, this guy's going to come get me. Okay? And I'm going to have an MUI, and someone's going to say I was neglectful, or someone's going to say you're going to go on an abuse registry, and by the way, I'm not going to play attorney, but I mean, you don't have to be convicted of anything to be on the abuse registry. And you don't have to be convicted of anything to have substantiated neglect against you. You don't have to, I mean, from a legal standpoint, these are decisions that are made by people outside of the legal realm. So now the staff go, that's great. How could that affect the rest of my life? And then on top of it, we now have a system that I call as the flavor of the day. Our mental health system, Ross, is just doing gangbusters from a financial standpoint, right? It's really good. So you folks out there, what do the referrals look like that you're receiving now? that blurred line between, do I have a, this type of a level of care, or do I have this type of a level of care? Well, we're swaying our way, folks, because we are perceived as the system that has the money. We are perceived as the system that has the political clout. We are perceived as the system that can frankly take care of about anything anymore. At the same time, everybody can sleep like kittens at night and doesn't need any support. That's what this guy is right here. We don't really need any of these because we don't really believe in formal behavior support plans. We bury methodologies in the body of the ISP, and so therefore all the money that we need to properly train staff to deal with these issues, it's almost impossible to get. And then medical add-on, boy, I tell you, I can't remember the last time that I asked the provider if you had any medical add-ons, and they kind of look at me. Because everybody knows if I ask you a question, you better think about the answer because I have a reason why I asked the question. Well, I asked the question because most people don't think of what qualifies for a medical add-on. And the one that almost everybody misses, except for this guy right here, because he did a tremendous amount of work on the subject matter, is oxygen. Okay? And we miss it. That's $5 grand a year, folks. We miss it. Adult day services. What's Olmsted decision going to do? How are we going to do employment first? And I don't mean this in a facetious or negative way. It's a wonderful idea. I wholeheartedly agree. How are we going to make it happen? That's the next question. What's it going to cost? Where's the money going to come from? In the ICF program, we have the state cap. We have downsizing, which will increase the cost in the system. So what will happen next year is we'll have more cost in the system that won't get covered. So what will happen? We'll have to decrease the ceilings some more. So when we're thinking about our downsizing plans, it's like, that's really great. We get the downsize and we file a 90-day cost report and we get our costs covered, and that's all about me for that first year. And then the next year what happens is, for the whole system, including you get to watch everything drop a little. Because financially, without that state cap going up, that's exactly what will happen. That will be the next financial phase. Conversion to waivers. I think we've talked about it. The carrot out there is you get the add-on to the rate for 1 year. I mean, it's a very attractive carrot. It lasts 1 year. DRO, DOJ. Your guess is as good as mine. You've heard everything you've heard today. Our biggest issues. The average cost per capita, per individual in the waiver continues to rise. As we continue to downsize, as we continue to convert, as we continue to do these things, that number will continue to grow. Rates keeping pace, they are not. I think we all know that. New CMS rules on community. What financial impact is that going to have once that reconfigures our system? Room and board, cost to live. Basically, I can tell you that I work with a lot of providers across the state on the room and board issue. The county boards have taken a pretty unilateral stance. They think people should live on their own resources. In fact, we have COGS now that are saying, have written documents saying that that's our goal. We're going to get people, regardless of what we're paying today, we are going to negotiate contracts in the future to get people living on their own resources. This is a subject matter that has always been near and dear to my heart, only from the standpoint of I don't like to see people living on the wrong side of the railroad tracks when they weren't born on the best side of the railroad tracks. It's just a personal issue I have. We all know what happens to cost to live. You guys are subsidizing it. Let's just be honest. And the ones of you that think you're not, you are. And I can tell you all the ways that you are and you don't even know you are. We're loaning people money when their electric is going to get shut off. We have no clue when we're going to get the money back or if we're going to get the money back. I mean, these things happen every day with every single one of you on the waiver side. I haven't seen anybody yet who has perfected it. We are the flavor of the day. And I put that in there for a reason because, believe me, everybody knows it and everybody is flooding to our system. What are our opportunities? As I see them, and it's only me, because I want input. DC downsizing, over time, if we were to eliminate the developmental centers, we could effectuate a savings of about $22 million in state matching funds. That's a huge number, folks. That's $50 million of services, okay? It's a huge number. County Board Medicaid subsidies, $400 million. The state match portion of our current IO waiver for 17,000 people today is about $400 million. So when you start thinking about waiting lists and you start thinking about all these initiatives, that number is astronomical. I have to put it on the list as an opportunity. Medicaid core nursing services. How many of you provide services both in an ICF and on the waiver? How many of you people don't provide services in an ICF, but you do have a nurse? You're a nurse. I know who's not telling me the truth. I know you guys. Okay? How's it getting paid for? It's not. Okay? How many of you considered becoming home health care agencies? Here's another question, because you all can't. I mean, this is not send a little letter into DODD and get my certification, you know, add this to the laundry list. It's not that simple. This is a laborious, expensive process. How many of you considered this? Do home health care agencies have a retention problem? Absolutely. Even if you secure core services for someone that you're serving, how often do they actually show up? Which is another whole nother issue. Have you considered subcontracting with them and providing them labor? That, I would say, could be a win-win. Okay, attorneys, have fun with that. I'm throwing it out there because we're in these intenable positions where the money is being pulled away from many, many, many different directions, and the expectations continue to do what? Okay? I'm going to throw out one other thing because I'm going to go back to the MUI subject. You know, a med-air, a simple med-air now is, and you saw it on the listserv last week, that could be neglect. A simple med-air, even though the provider took every precautionary measure possible, did all the right things, the staff person made a simple mistake that did not cause any harm to the individual, and now they get neglect labeled on them. And all of the process that we go through to get there, which is extremely expensive to our system. Okay? So, but we're continuing to be told that, you know, this person only needs assistance with medication, this person doesn't need delegated nursing, or this person doesn't really need any nursing. But at the same time, we all know, frankly, that there's a lot of half-truths in all of those statements. So what do? We do the right thing. Unfunded. Okay? So, I mean, I throw that out there because this has to get serious conversation in our field. Overnight routine homemaker personal care versus on-site on-call versus remote monitoring. There are financial opportunities in that, and we already know the flip side. And the flip side is a whole bunch of you are providing staff at night that are awake because they need to be awake, and you're getting paid on-site on-call. And when I say many, I would be surprised if there were many in the room who aren't doing that. Okay, because it's been pushed so hard, and financially, it's killing us. Stabilization needs. I've got more question marks than I have dollar amounts. In a private ICFs, arguably, if we had $9 million of state match, we could do a whole lot to fix the current ICF system. In a budgetary process, $9 million is not very much money. The problem is the stigma that goes along with it. It's contrary to the department's initiative. The cost of private ICFs downsizing. We don't know yet, but there's a number of us that could run some models and we could figure it out pretty quick. But there is a cost associated with it, and it's going to continue to be problematic in the state cap for everybody in the room. Because as that occurs and the cost of the system goes up, it's going to drag the ceilings down for everybody. HCBS waiver, homemaker personal care, and transportation. I have estimated to update the EMP&P models and even get the transportation rate up to the reimbursement rate for private use of business of an automobile, which is about 57 cents a mile. By the way, that will not pay for your adaptive transportation. We would need $30 million in state match. HCBS waiver, adult day services, and non-medical transportation. That's been a silent subject matter in the budget. Silence. Nobody has really talked about it much. I think I saw one thing on the listserv where someone said, when there was announced that there would be rate increases, someone asked if this was included. That's another rate that hasn't changed in now 9 years. Both of those rates. Level 1 conversions to the IO waiver. They're happening every day. I'll give you an analogy. When we have an ISP process that takes a person on the level 1 waiver and now they live with 3 other people because mom just went to the nursing home and can no longer care for me anymore, and I go into that setting and the ISP says that I need assistance with laundry and I need assistance with cooking and I can't access the community by myself and I can't be alone and all of these things, and then it puts in there a sprinkle of 4 hours a week. I just want to paint a little picture for you. You and I get in a car accident together. Ambulance shows up. You have a Medicaid card. I got nothing. I don't have any private insurance. I don't have a Medicaid card. I got nothing. We get to the hospital and they start to treat us. Can I borrow your Medicaid card? I need to pay for my services. Can I borrow your Medicaid card? That's what we're doing, folks. We're using somebody else's waiver to pay for their services. And I am pretty sure, help me attorneys, I'm pretty sure that's not okay. And and that's not an invisible elephant. We're not, we're not so special that the other Medicaid agencies aren't going to come look at us. So when we talk about fraud and abuse earlier, that's a serious issue. So now we're starting to pretend. TDD waiver, conversions to IO. I frankly think we're waiting for these people to get so old it won't matter. I mean, what are we doing? We don't have any waiver slots identified for them. That's another pressure in the system, and there are already discussions about them sharing services with people on the IO waiver. They're just trying to figure out how to do it.
They're not even the same.
Huh?
There's no homemaker personal care.
No, there isn't. But we can always pretend. okay? Pretending's a great place. Anybody ever been there? I try to keep it in my dreams only. Employment first. I'll say it again, it's a wonderful idea. I think every person with a disability ought to be afforded the opportunity to work. I think every person with a disability ought to be afforded all sorts of things in our society. That's why we're all here, isn't it? But that's going to put financial pressure on our system, and what is that going to look like? New CMS rules. Like I said, I have more questions than I have answers right now. Companionship exemption, I'm not sure how big it is in our field. I know it affects certain providers. Obviously, not many that are here today. I didn't see anybody raise their hands. But these are all things that we need to start collecting information on for the next state budget process. And we need to frankly start doing it now, because November will be here before you know it, and that's legitimately when the process starts from the governor's budget perspective. So I'm looking for people with answers. He who goes to the ISP meeting with the most what wins. You have got to have information. You have to be prepared. You have to be able to be a leader in that team meeting. I don't mean you're taking over the SSA's function, but you have to be a legitimate team member, and you have to bring information to be able to do that, and you have to speak your piece. If you don't, then there is no chance. And you have to formulate that respectful relationship over time. And by the way, this discussion isn't about whether I think county boards are good or bad. It has nothing to do with that conversation. It has everything to do with, we have resources and limited resources in our system, and folks, compared to most states, our limited resources are wonderful. Okay, so it's difficult for us to whine too much, because compared to most states, we look pretty doggone good, all right? This is a conversation about how do we utilize our resources and realign them with the department's initiatives, the administration's initiatives, CMS's initiatives. How do we do that? How do we effectuate that? How do we use the money wisely? This is a pretty big guide. We're doing a whole bunch of stuff for free, and I'm going to throw one more thing on top of that. And I'm not an attorney, but I say that quite often, it seems like. If I were providing a nursing service that I'm not authorized to provide and something goes wrong, I don't want to be you. I don't. And I don't mean that meanly. I mean that in a very affectionate way. I don't want to be you, because you are not covered by the Good Samaritan law, I don't think. Because you didn't stumble on somebody walking down the street and tried to do the right thing and it ended up being the wrong thing, but you tried to do the right thing. You are contemplating and doing something that you're not authorized to do. And that's, I don't want to be you if something goes wrong. That's why we have to effectuate the correct services that we're providing, and we have to do them within the confines of the federal, state regulations. We can't just take it in our own hands and go do whatever we want because we think it's the right thing to do. And I commend you all for doing it, because from a humanitarian standpoint, I commend you. But from a system standpoint, it's not helping us. There are opportunities in this. We need to work together to formulate what those are in the next months to try and effectuate them.